Okay, good morning, everybody. Welcome to the Woodrow Wilson Center. I'd like to just tell you a little bit about where you're sitting. The Woodrow Wilson Center is the living memorial to our nation's 28th president, the only president with a PhD. As such, we like to bring together the academic and policy circles and share ideas, share conversation, and see what comes out of it. A little bit also about the Global Health Initiative, the program that is hosting this event. The Global Health Initiative was formed about 6 months ago here at the Wilson Center, as we noticed a trend that several of our regional and topical programs were kind of organically hosting lots of events dealing with health. So we decided we needed a department that could house all of these things together and then come up with some original programming. Global health is, of course, a massive undertaking, and it could be as big as this whole center. So we've honed it down to about 4 specific topics: health's impact on development, the role of international and national institutions in global health policy, infectious diseases, and emerging health technologies. Arguably, today's presentation touches on 3 or 4 of those, especially the first 2. So a little bit about our speakers today. Maureen is an advisor to the Senior Vice President for Human Development at the World Bank and is a non-resident fellow at the Center for Global Development. She specializes in the economics of health and education. She was formerly the chief economist of the Human Development Network at the World Bank. Prior to that, she managed a unit in the bank dedicated to economic policy and human development. Before joining the World Bank, she established and directed the International Health and Demographic Policy Unit at the Urban Institute. She is an adjunct professor at the George Washington University Graduate Program and is widely published. She earned her PhD at Johns Hopkins. Rubén Suárez has spanned North America throughout his career. He's the regional advisor in health economics and financing for the Unit of Health Policies and Systems at PAHO, the Pan American Health Organization. He has more than 20 years of experience as an international consultant for such organizations you might have heard of called the World Bank, USAID, and the Inter-American Development Bank, and also national governments and the National Bank of Mexico. So with that, I'd like to get started. And Maureen, the table is yours.
Okay, thank you very much. It's a pleasure to be here. This is work that started when I was a senior fellow at the Center for Global Development, and it's I'm expanding it from that. But this is sort of the core of the study. It's a longer study. If you want, there's a policy brief outside if you'd like it, and if you go to the website of the CGDEV, so cgdev.org, the full paper is there if you're interested, or you can ask me for it and I'll send it to you. Okay, so let me tell you what I'm going to tell you. I'm going to talk about what corruption is and poor governance of the health sector. I'm going to talk about the importance of poor governance to health outcomes, and I'm going to talk about how you measure corruption and governance, and then what to do about it. One of the things that I think we find in development in general is that health and education as well are considered things that help people. Therefore, we're not going to worry about whether or not there is a problem in getting services to them. Just doing those services is enough, getting them the money, and making sure that they have the funding that they need to go forward. And one of the things we haven't done very well, and I think many of us in the World Bank are also to blame, along with I think the broader community, is that we really do have to bring some rigor to this and say, well, are we doing what we think we're doing? Are we having the outcomes that we think we're having? Are we actually achieving our objectives? And I think part of my motivation on the governance side was entirely that, as well as the fact that if you look at some of the other areas of development, there has been a good deal of concern about these kinds of issues. And we've found that if we fix some of these problems, some of these governance and corruption problems, we end up with better programs and better impacts. So that's the motivation behind it, and it's been somewhat controversial. However, I think it's worth a discussion, and I think that this is sort of just an initial foray, and hopefully we can go forward and look at some of these things in the future with a little more of a critical eye. The MDGs, I think, have also helped that. The objective is to have some clear outcomes, but there's been an emphasis on investments, which is fine, and it's certainly part of the issue. Secondly, there's a question of cost effectiveness. Now, the way we use cost effectiveness in health is to say, well, if it's cheap and it can work, and we know it works, it's a magic bullet, we've got it made. Well, that's true, but on the other hand, 30% of kids still aren't immunized, and we've had those technologies for a very long time. And we do have oral rehydration therapy. We have other kinds of interventions that are critical. The question is, are they getting where they need to go? And finally, as there's been a scale up, and I think this has been a bigger issue in AIDS than in health, is there an ability to absorb this money? I mean, one of the things we've learned in the U.S. is when they set up Homeland Security, they did it very quickly and they put a lot of money into it. And when they did the evaluation 3 years later, 3 different evaluations by the GIO, the Internal Inspector General, and someone else, all said the same thing. That money was effectively wasted. And that does happen when there's a rapid scale up and you don't have in place the pieces that you need to use that money effectively. And so the whole idea of trying to spend more to do good is obviously highly desirable. The question is, do we have in place the pieces that will allow us to do that? And what poor governance does is that it undermines all of these objectives. And so we have to pay attention. So a lot of what this slide says is what I've already gone into. But I think one thing that's important is the Kaufman, Cray, and Matsuri components of importance. They have 6 indicators that they use for what is corruption. And they are looking at governance, which is sort of how do you govern well, how do you have an honest and effective program, and then the question of corruption, which is a lack of governance. And what they have done is they have 6 indicators. One of them is that you have a legal system, and that's clearly important. But 3 of the 6, I think, are more relevant to what we talk about when we're interested in health, and one is government effectiveness. Can government be effective in providing services? Secondly, can they control corruption? Because controlling corruption is obviously part of getting your services delivered. And third, what about voice and accountability? And voice and accountability apply to whether or not citizens can have a voice in terms of what happens to government programs, whether they are listened to, whether their views are taken into account. And the accountability is, who are the health providers accountable to? Who are they answering to? And this is one of the biggest problems in health, because if you decentralize, you're decentralizing to the local level, but you're being paid by the central government. Then who are those providers accountable to? Who do they answer to if they don't show up for work, if they're not doing a good job? And so these kinds of issues become very important in terms of having a good government and having effective health care. So what I'm going to do is look at some of these things and look at the kinds of indicators that there are to reflect them. And corruption is the use of public office for private gain, so that it means that I'm benefiting because I'm using my public office to make money. I mean, it can be in any sort of range of that. It's a very general definition, but I think it helps us because it's the basis upon which we go forward. The fact that health has never been considered corrupt is rather interesting given this graph. I hope you can all see it. But what it's based on are a lot of surveys that the World Bank and some other groups have done asking businessmen, citizens, and government officials, is there corruption in your country? And then pursuing a lot of questions. A few of those interviews have asked about health specifically. And what this reflects is the answers to those questions. Now, there's a relatively high correlation between health being a corrupt sector and the overall government being perceived as corrupt. But in some cases, it's not so strong. And in a number of countries, the health has shown up as the most corrupt sector, and that's been true mostly in South Asia and the former Soviet Union. But as you can see from this list of countries, it really spans all of the regions, and that corruption is a concern in many of those. So there is a sense that corruption is a problem and is something that we should be paying attention to. So if I go back to the issue of the Kaufman, Cray, and Matsuri framework, and you look at the plots of the effectiveness of government and immunizations, and I did this with infant mortality, but infant mortality has some other issues we can talk about if you want to. So, but I think immunization coverage is a better indicator purely for health. And if you look at these, if you look at the R squares, essentially what comes out the strongest is your government effectiveness, followed by the control of corruption, and voice and accountability is sort of all over the place. I mean, there doesn't seem to be a very firm line, so you're not quite sure what you're getting there. There doesn't seem to be a very good relationship. But in the other two, it's stronger. So that gives you a sense of using a quantitative indicator, how that relates. Okay, I did some regressions. I looked at what the determinants were of immunization coverage, and I did this also for infant mortality. And basically what I found was that, again, the government effectiveness indicator was positive, it was robust, it was significant, and it was consistent. So I basically said, all right, this helps me take that into account, because I'm controlling for other things. I'm controlling for GDP, which wasn't significant. I was controlling for education of women, and it was somewhat important. And then I controlled for what we call ethno-linguistic fractionalization, which is a way of measuring how non-homogeneous countries are. Because more homogeneous countries, you would expect, would have a better chance of having immunizations being lower and having lower corruption. That was significant. So essentially, the government effectiveness, when you control for other factors, also comes through as important in terms of getting immunizations done. I apologize. So then, how do you separate governance from corruption? Because we don't want to say, well, corruption is the problem. It's only a symptom of a problem. So what are some obvious areas? If you sell a government position, if you have to pay to get a government position, that's pretty straightforward corruption. If you're taking kickbacks when you're procuring for goods and services, that's a form of corruption. If there's outright theft, that's corruption. It then becomes less clear when you have other things. What happens if it's simply mismanagement or inefficiency? That's not really corruption. That's just bad management. It's hard sometimes to separate these, because bad managers will let theft go on, but they themselves are not a corrupt individual. Incentives are often wrong. And that's one of the, I think, the big problems that we have in health, is that the incentives to the providers are not always very good. So that if I come to work, I get paid. If I don't come to work, I get paid, and I get paid the same amount. So my incentive to come is not very strong, and this has been a chronic problem in a lot of countries. Is that corruption, or is that just bad management and inefficiency? If you track performance, you can have a better idea of what's going on. If you don't do it, it's not really corruption. Again, it's just mismanagement. So I think that it's important to sort of see a bit of a distinction here, that everything isn't a corruption problem. Some of it is just bad management and inefficiency. So if we go to some of the elements that characterize these factors in health and in healthcare delivery specifically, first is drugs. Drugs are portable. They're relatively inexpensive. You can make an enormous profit on them. People who want them are willing to pay a great deal. So drugs go missing, and we do find that in a lot of countries where we have data that drugs seems to be a big problem. In Costa Rica, they did a lot of qualitative work and some quantitative work. What they found was 32% of users who had gone to the pharmacies, government pharmacies, were aware of theft. Okay, so they're reporting what they've seen. In Uganda, they did work in 10 rural areas over 2 months, and they tracked them. And what they found was that 73% of the drugs disappeared. And ironically, some of the people who took the drugs were the people on the oversight committees. So there was a problem. In China, they know that about 30% of the drugs are expired or counterfeit, that there is a secondary market there. We've found the same thing in Nigeria, and Nigeria has done actually quite a bit to try to clean that up. But we are accumulating data that suggests that this is a problem. If you look at something like equipment, some recent studies in Ethiopia and in Nigeria showed that a lot of the equipment was either not there or missing or broken. This is not surprising to people who've worked in the field. You find this a lot. Part of it is that repairs are very hard to get. And so what happens is that they'll come to the donors and say, we really need more X-ray machines. You go, well, there are a lot of X-ray machines. Well, yes, but they don't work. Well, what's the problem? Well, they need a $10 part. And so these kinds of things do happen, and it creates a lot of problems. But what it does, it also makes government services much less effective. So if we look at pricing and procurement, which again is probably an area where corruption is more likely, what I've done is I've looked at some data for hospitals in 4 Latin American countries and looked at the variability of price. And here you can see, for cotton, there's a really big disparity across hospitals, but there's less so in the other countries. And interesting, in Argentina and in Colombia, which you see here on just for two of the items, they have guidelines for what hospitals are supposed to use to procure. So there's much more control, and there's more auditing. There's much less so in Bolivia. And so you see more variation. And although that doesn't say it's corruption, it is rather suspicious. What about leakage? Something that the World Bank has started to do that has proven quite useful in trying to figure out how well some things are working across sectors. But they've actually started with health and education. And what they've looked at is leakage. If the central government allocates a certain amount of money for health clinics and hospitals, how much of it actually gets where it's supposed to go? Which is a pretty logical question to ask, but has actually been quite revolutionary. And in health, in the majority of countries, we have not been able to trace that money. So is it corruption or is it an inefficiency? We don't know. But even here where we see the leakage rates, and leakage can mean it just didn't get out of the federal government or the national government. It didn't get beyond the local government. It can be that it disappeared. It can be anything. And it doesn't mean it's corruption. It can just be inefficiency. It can be that you were supposed to get your budget by the end of the fiscal year and you didn't get it. You got it in the next fiscal year. That's not very common, but that's sort of the extreme. So essentially that means the money has gone missing. We don't know why. Can be, and the numbers are relatively high. You have a leakage rate of 80 in Ghana and close to 70 in Peru and Uganda. Tanzania is less of a problem, and 40% leakage rate may not be so terrible depending on where it's ended up. But what this says is things are not working like clockwork, and we can't assume that they are. Okay, something I mentioned already were absence rates. Now this is something that has been anecdotal in developing countries for a long time. I did a study in the late 1980s in the Dominican Republic, and I could only account for 12% of physician time. And the nurses were there some of the time, but you also found that by 10 o'clock in the morning there were no physicians. There were also operating theaters that were only working for 4 hours a day, leaving them closed for the rest of the time, which is a very inefficient use of resources. Is that corruption? No, not really, because that's just inefficiency. But the absence rates, again, it's really a question. The same study in Uganda that I mentioned before, they found absent rates of almost 70%. Well, they didn't have any drugs, so they figured, well, why should we be here? But there was no one to say, you must come to work. And so people didn't have to. And one of the things we find from sort of probing beyond some of these indicators is that there is a sense that the equipment is broken, there are no drugs, why should we show up? And there's also the sense of, yes, I'll show up, but I don't have to, because no one's going to make me, in a sense. And that's a lack of accountability. But it is quite, I think, dramatic in terms of the rates of absence. And most of these are surprise visits. Yes?
Aren't some of them looking at alternatives? They're private clinics, and that's why they're not at that job.
Yes, they can be. And the qualitative studies have said they have other jobs. In some cases, none of the ones that are here. But they did some work in Ethiopia and in Mozambique. Mozambique is here. No, I'm sorry, Nigeria. And in both cases, they said, well, they hadn't been paid, so they didn't show up. But if you look at some of the rest of these countries, in Bangladesh, India, Indonesia, Honduras, Dominican Republic, issues of non-payment of salaries hasn't been an issue. So yes, it can be an issue, but that doesn't mean that just because I have another job, I don't go to my public job. And that's a problem. I mean, if I contract you for 6 hours a day and you show up for 1 because you have another job, then I should be hiring somebody else to do that job, not you, because you have another job. And that's the problem, because I'm paying you for 6 hours, you're only providing 1 hour, and I, as a government, have really let down the public because I'm not fulfilling my obligation and my commitment to them. So that's where the problem comes in. But you're right. I mean, a lot of people and many people in many countries, as those of you who have worked in developing countries, it's very common. I mean, I've been to countries where people have 4 jobs, so they do all of them a little bit. Another area that has become, I think, much more obvious as an issue is informal payments. And informal payments are payments under the table, not going to a cash window, paying people on the side, usually to a physician or to a nurse. There's been a lot of work done on this in the last 5 years in Cambodia, in Tajikistan, in Georgia, in Poland. There have been a number of studies, and what they find is that in some countries, every single activity is individually financed. I'm on a gurney, I want to move to the bed, I need an orderly, I pay the orderly. I need a physician. I go to see a physician before I need them because then they're on retainer. And you find this public market underneath the public sector partly because the public sector is free, and the physicians aren't paid very well, and the nurses aren't paid very well, and so they start charging people. We know that this is the way that healthcare is being financed in much of the former Soviet Union, certainly in China. But I think what's remarkable is that the highest reporting of informal payments are here. I have my point. Are here, which are in South Asia, and Pakistan and Sri Lanka. You see it in Kyrgyz, you see it in Moldova, and then you see it down here in Vietnam. And these are just the countries for which we have data. We have a lot of anecdotal evidence, but we don't have data. And this all comes from surveys that have been done specifically about this question. Some of them have come from household surveys. How much did you pay the last time you went to the doctor? So we know that this is a big issue. Okay, and if you look at what that means in terms of household spending, I'm sorry. Oh dear. Now there we go. If you look at the yellow line is inpatient, which is not surprising. That's expensive. But what you find is that in some countries there's very little. And the studies that have been done alongside this have basically said, well, most people don't seek care when they have to pay for it themselves, especially for inpatient care. And when they do, they often have to sell assets. That means either selling a cow, getting a loan, borrowing from family. Those are the most common kinds of ways people finance it, because it's no longer a pooled group of a population that is supposed to be provided health care based on need and of pooling risk, which is essentially what a public health system is supposed to do. So essentially, because this is the line of 100%, you can see that in Bangladesh, when you go to the hospital, you spend over 200% of 1/2 of monthly income which is roughly median income, on your inpatient event. So essentially, people are paying a lot of money and for free care.
These are public sector hospitals?
These are all public sector. This is all public sector. This is not. There's no private in this. If you look at private, it's different. But the thing is, with private, the assumption is that the people who have money will pay. The problem is, with a public system, it's supposed to be a system of equity and of shared risk, so that who needs it can get it when they most need it. And inpatient care is something that you want to pool your risk on, because you never know when you're going to get really sick. And it tends to be a random event. It could be your foot. So the other question is, are patients satisfied? And it's not a question of, do we have a beautiful hospital, but do they think that they're getting their health care? And one of the things we find about countries where informal payments are quite rampant is the decision on what things to invest in become distorted. And my favorite example of this is a hospital in Azerbaijan that was crumbling, basically, and they had one ward that they had invested in, and they were building a huge fountain in the middle of the entryway. And the reason they were doing that is because it gave an image of the hospital of people who would then come, and everything was being paid for by those people. So that was a big indicator that something was wrong. Okay, so are patients satisfied? Corruption is common. Out of 23 countries, health ranked in the top 4. I think I mentioned that earlier. And where they've done surveys, they find a lack of non-labor inputs, limited hours, and low quality of care on the perceptions of patients. So what do you do about it? Well, there's mixed evidence on how much raising salaries matters. In a lot of cases, we've found that it doesn't have much of an effect. We do need better incentives for health workers. They may need employment security. Actually, may be a problem, and we can talk about that if you want. Recruitment and promotion criteria are not always very clear. There may not be more than one promotion in one's professional life, which is a problem in terms of getting people to come to work and be rewarded for good performance. Capable management is important, and it's been undervalued. You need to raise accountability. You may have to hire and fire staff locally. That's one of the things that's come out of some recent studies. If you can hold them accountable locally, if they don't show up for work, you can fire them. That has an enormous impact on their behavior. Improved insights. Sometimes inspectors are good. Sometimes they are part of the problem. So I caution that, but it has worked in some places relatively well. Audits are important, especially where places are collecting fees. If you audit, you at least know what's going on. There's somebody who is providing some oversight so that the financial procedures are followed, so that the money is where it's supposed to be. We have to address who pays. I mean, one of the things we've found, a couple of studies, one in Cambodia, one in the Kyrgyz, basically showed that if you formalize fees, the informal fees go down. And the reason the informal fees are bad is that it's a form of corruption. You're paying the individual, not to the hospital. So there's nothing being invested in the hospital. It's just that the wages are going up for the health workers. And that doesn't seem to be a very satisfactory answer. You can contract out with a pay for performance, which is you pay according to what people do. And we've adapted a lot of those in the United States as a way to monitor who is doing what. That doesn't mean it's corruption-free, but it's a way of holding them accountable. Citizen report cards, where citizens within communities evaluate and assess the public services, and that's taken into account by the central government and decisions that they make. And local oversight can work. I mean, I talked about what happened in Uganda with the 10 clinics, and that's a problem. So you can get what we call local capture, where they become corrupt as a group at the local level. But presumably, we know there are other places where some of this can work. And so that's another potential strategy. So what do we do about controlling corruption per se? One is an anti-corruption strategy, quite helpful in Poland. Got good evidence on that. We're seeing that in other parts of the world as well. Sometimes health or any single sector can be outside a drive to improve it, but it's harder for health to take on anti-corruption alone than to have the national government define that and then health piggyback on top of it. We need a database of staff. There are a lot of absent staff, but there are also ghost people who are being financed. And when they've cleaned up some of in Zambia a few years ago, they had a big problem of staffing, and they did a database. Figured out who was there, and they found that something on the order of 20% of the people were dead, had retired, or were not eligible. So this can be this is relatively easy, but it can have high impact. So you want to improve records and oversight. Part of the reason we couldn't track money is because there were no records. So that's something simple. Cost of supplies will decline where you have price lists and you have guidance on what hospitals or clinics should pay for in terms of buying their supplies. That's sort of obvious, but it tends to not be very common. More information to citizens about public health, what's expected, what the performance is, and what they can do. Because communities and individuals don't always know, and the difference between doctors and the public tends to be quite a chasm in most places. Make the government accountable to communities. Ask them, get their input. So on voice, which we talked about before, and we saw that weird scatter, that very highly variable scatter. What we found is that voting and NGO presidents don't have very much of an effect on corruption. It tends to essentially stay the same. Although local organizing groups tend to have a positive impact. We see that in one country, but it's an indicator that maybe we should be doing more in this to see what works. In Uganda and the Philippines, voter turnout had no effect on corruption and health. But, you know, health is just one thing people are voting about. So it's not surprising that it didn't show something very, very robust. It may be too blunt. So let me just conclude, since I've taken up my time here. The returns to health investment may be very low if corruption and poor governance are a persistent problem. And secondly, institutions matter. It matters that you have a health system that is held accountable, that has procedures, that follows through, and that shows what they do. Institutional factors do need to be strengthened, and you need to spend more perhaps to do so. But to improve performance, you need more than just more money. Also, we need more evidence. I mean, what I've presented here is all over. It's fragmented, it's in different places. There's been very little repetition of the same studies. The only real exception here are the corruption perceptions and the absenteeism. But those absenteeism take different kinds of measures. But if we have more, I mean, my paper is riddled with examples that don't lend themselves to putting on a slide. And part of it is because we don't have that much evidence. And finally, my own view is that health can't be sidelined in the overall corruption debate. It's become an issue for many donors, for many countries, and health needs to play a role in that to upgrade both health and to make sure that we're getting both good services but also sound government. So thank you very much.
Well, thank you very much, Maureen. Before I turn over to Rubén, I'd like to remind everybody that this presentation will be available on our website, which is wilsoncenter.org/GHI, or Global Health, excuse me. And also available will be her presentation and a meeting summary within the next few days. Rubén?
Well, let me thank the Center for inviting me to participate at this conference, and to Maureen for the paper, to comment on the paper on governance, corruption in public healthcare systems. I have been asked to comment on Maureen's findings, basically and try to take those issues related to governance, corruption, and management as they relate to public healthcare systems in Latin America and the Caribbean, where I have focused most of my work in the last 5 years. Let me tell you at the beginning that I am not an expert in the field of corruption. I've been following the literature, but many of the topics that Maureen mentioned, absentees, ghost workers, leakages of drugs, loss of equipment, untracking the use of funds, are the type of issues that we deal in every mission that we go to work with governments. We have to address those issues with the governments. So it's part of the regular work that we do with the governments that we want to address these issues of how we can improve in those areas. The second point that I want to make is that I think the issue, what it was presented, the governance, corruption, and mismanagement, I think mismanagement need to go in the title of the paper of Maureen. I think it's very important because with this borderline between corruption, mismanagement, and governance, that I think is very important to have at the beginning that there are some borderlines in which we're not sure what we're talking about. Okay? The second point is one of the conclusions from Maureen that in fact most of the data that we have is very soft data about perception of corruption. And one of the issues that I want to present is to give you an idea of when I received the paper, I said, how much has been lost due to corruption or just due to these inefficiencies. So I want to have an idea of the magnitude of resources being wasted in public healthcare systems due to mismanagement, corruption, or lack of governance. And I will give you some figures later on to give you an idea of the difficulties that we have in trying to see how we can address these issues of governance and corruption given the structure of the healthcare systems in Latin America and the Caribbean. With regard to this issue of corruption per se, I came to work on corruption not so much from the health sector perspective, although I said many of these issues were part of the typical agenda that we deal with governments, but in the context of the economic growth and economic development literature. And one of the issues I want to call your attention is that maybe until late 90s, there was a theory about corruption as an alternative to accelerate economic growth. And there is extensive literature in which developed countries used to argue that some cases it was acceptable to provide some bribes to government officials to allow to introduce some policies that will allow for long-term economic growth and development. And the basic idea was that the government were so inefficient and were so against economic growth that there were some ways in which, since developed countries knew better the policies that need to be put in place, some bribes were allowed to promote this type of growth. I seen the paper from Vito Tanzi from the IMF, a son on the world in the IMF, lately in the last few years, put on relevance the type of issue that corruption in the sense of paying bribes to government officials to try to do something in terms of policies was a general practice since the 60s and 70s. And it's also important in the health sector too. You will see that until the end of the 90s, many of the international organizations used to create some type of incentives to countries and governments or government officials to try to introduce some type of policies. So let's move from this type of, and I think the literature on economic growth and development said even though in the short term they could be beneficial to try to do this corruption in terms of trying to achieve the goals of implementing a particular type of policies, in the long run, they have adversely affect the long-term economic growth of the countries, in the sense that lack of governance, lack of accountability have created a series of disruption of the functioning of the health system that in the long term have produced very pervasive results on how the system works. So let me go to the paper presented by Maureen, giving this background on corruption and governance and mismanagement. I agree with many of the conclusions that Maureen presented in the paper, and I will refer to them at the beginning in case that I run short of time. The first thing is that we need more data. And I think the data, although it's very anecdotal data and give you some clues on the importance of corruption, we need more data on try to see how important is that. And let me give you an overview of how much is being spent in countries of the region. If you take the Canadian healthcare system, they spend 11% of the GDP. The US system spend 14% of the GDP. Latin America and the Caribbean spend around 7% of the GDP. When we ask how much is being spent by the public sector, I will ask you to step back and see what is the public sector in the case of Latin America and the Caribbean. And I will say they have three components that are very important for you to have into account when you want to see how corruption may be affecting different type of market. The first one is the central government. You ask me how important is the central government in Latin America, and I would say it accounts for 20% of national expenditures. Then you ask me how important are local governments, and I will tell you it accounts for 8% of government expenditures. How important is social health insurance? And I will tell you, well, it accounts for another 22, 23% of national expenditures. So public expenditure account for approximately 50% of national healthcare expenditures in Latin America and the Caribbean. The importance that I'm giving you this market structure is because many of the issue of corruption or mismanagement or quasi-rents that are at the core of the possibility of corruption have to do with the market structure in which you are dealing with. And therefore, dealing with the possibility of quasi-rent in central governments, in local governments, or in a social health insurance system is of a completely different nature of the type of quasi-rent that we can capture in the private sector and that are recognized as it's okay to capture those quasi-rents. So I gave you this picture of the Latin America and the Caribbean. And then I asked if we move across countries from north to the south. I said, how important is the public component on that? As in, we find countries in the poorest countries of the region in which public expenditure represent less than 2% of the GDP. To give you an idea, in the US, public expenditure through Medicaid and Medicare is around 6% of the GDP. In poorest countries of Latin America, we spend
60.
6% of the GDP, Medicaid and Medicare. So in many countries of Latin America, when we're talking about central government operations, we're talking about expenditures that amount to $14 per capita, $10 per capita, $12 per capita. In the US, we're talking about $3,000, and it's not because there is no possibility of corruption, it's because the magnitude of corruption that we are talking is only a very small component of the total expenditure that is done in the country. And that's when I come with the second conclusion and agreement with some of the conclusions from Maureen Lewis' paper, in the sense that good governance seems to be very important for the efficiency and the way in which healthcare system operates. And let me give you, I told you the lower bound is 2% of the GDP, and we're talking about countries of Central America, some countries of the Andean region, Haiti, but we have countries who spend around 6%, 7%, or 8% of the GDP. And we're talking about Chile, public expenditure, Chile, Argentina, Uruguay, Cuba, Costa Rica. And what is the main difference between these two countries? Chile, Argentina, Costa Rica, and Cuba have the best health outcomes that we observe in the region. So it's not only that there is a public expenditure there, but there is an amount of public expenditure minimum that is needed to run an efficient public healthcare system. And seems to be that many of the issues of governance have to do with the sufficiency of funds to put in place an adequate public healthcare system. So from that point of view, I think we need to look back, look to the corruption in the context of how the healthcare system operates. From the analytical point of view, I think there's it's also, I am talking how the way in which we are talking or conversing with government when we go to do some technical advice to the government. And we ask them, well, we need to separate different type of market in which you can have opportunities for corruption, and you need to address those type of issues. And I will talk on three type of markets: the market for healthcare services, the market for drugs and medicines, and the labor market. And the reason why I make this distinction between is because from the economic analysis point of view, you have a different nature of externalities or market failures that need to be addressed when you're trying to deal with corruption or with quasi-rents on addressing issues that appear as corruption in those three markets. For instance, when we're talking about healthcare services, we're talking about non-tradable goods. So most of the opportunities of corruption are between the provider of healthcare services and the people who are consuming healthcare services. That cannot be transferred to another person. So how do we deal with this type of payments, of additional payments to physicians for services that they provide, even though they should be providing healthcare services? And let me tell you, in many cases and in many countries, it's open and it is well known that physician will work only 2 hours in the morning, especially the specialized physician. They are willing to work only 2 hours in the morning to do all the surgeries that they do, and then they can do whatever they do in private practices or participate in community work. We also know that in many countries, the reason for why it is quite acceptable is because there have been some changes in budgetary allocations. The initial contracts that were stipulated to pay to healthcare workers are much below what they were initially set up. So it's not surprising when you said, well, there is an absenteeism. Yes, there is an absenteeism. That is the way in which the system operates, and this is the way in which we pay workers for doing that. Is that good? No, it's not that good. That's not good for managing a good healthcare system. But we need to put some policies in place to see how we can address that from the type of salary scale for the workers. Here I want to relate to another issue that is very important. When I said, for instance, public expenditure is only 2% of the GDP or 6% of the GDP, we have a serious problem in accounting and valuing public healthcare services. We don't know how much do we spend in providing those services. we don't know how much do they cost. Let me give you another example. It's easy to see in the newspapers in almost all countries of Latin America that a particular type of transplant was done, a particular public health care facility, and was almost free. Okay, was $2,000 was the cost of the surgery. The same surgery in the same country will cost $50,000. When we take how much the system produce, the public healthcare system, we're not looking to the market prices of the services being produced in the public sector. We're looking to how much has been paid to the workers in the public health sector. So from that point of view, I think if we want to do some real comparisons of the contributions and the significance of corruption in the public healthcare sector, we need to have better data to try to analyze how important and how pervasive may be this part of the corruption. I told you healthcare markets, the labor markets, the market for healthcare services have three different types of issues. When we talk about drugs and medicines, those are tradables, and the leakages go across the system. The corruption or the mismanagement of the system can go from physicians to administrators to low-level workers. And when we talk about labor markets, it's the way in which physicians are being hired or medical personnel are being hired in the health sector. So there is a second point that Maureen present and have to do with governance in the health sector is that we cannot look to the public health sector in isolation in relation to the private healthcare sector. I was surprised when I moved to Canada and I lived there for several years, and I tried to get some appointment with a private physician for a medical consultation. And I don't know, you cannot. I said, I am willing to pay. And they said, no, you cannot. And you cannot. You cannot pay a private physician to get a consultation. The market does not exist. It's not allowing the system to do those type of things. If you move in that environment, it's completely different in an environment in which if you are willing to pay, you are going to get what you get. Okay, you are willing to get the services. And therefore, having a good understanding how the market works is extremely important to try to see the distortion that are being created by the public healthcare system or by the wrong type of policy in the public healthcare system to try to assess the incentives for public health professionals or for health sector in terms of the relative prices in the public healthcare facilities and private healthcare facilities. So I think I agree with the other statement from Maureen that looking to the governance of the healthcare system, we cannot look only to the governance of healthcare system. We need to look to the healthcare system as a whole, in which we have the private health insurance market, we have the out-of-pocket expenditure market, we have the social health insurance, and we have the government public health insurance system. The second issue that I think is important and is between management and corruption is the issue of management. I think many of the issues that Maureen present, absentees, lack of knowing where the resources are going, the absentees, ghost workers, are management issues. And I think governments are trying to address those issues. But I think we have a bigger challenge. If we don't put in place policies that create a good governance for healthcare system, these management issues are secondary in terms of how important is to address the issues of corruption to try to improve efficiency and equity of healthcare system. And let me give you another example. Let me take you, I mentioned to you the importance of public expenditure for health outcomes. Now we can look to equity. That was the second dimension that I was asked to comment. We can ask how much the government distribute, how much of the government expenditure go to the rich, how much go to the poor, and what is the relation that we know in Latin America in relation to the organization of the healthcare system, and the importance of public expenditure to try to see how good is the public health system in redistributing income from the rich to the poor. The few studies that we have, studies from PAHO, that's something that we did with the World Bank and with ECLAC in Santiago, they reveal is we take all the countries, all the different healthcare systems, the healthcare system that have the largest distributed impact is the case of Chile, a system in which you have a social health insurance system part of which is run by private sector, but in which 40% of public expenditures go to the lowest 20% of the income distribution. And if you go through countries and try to see from the data that we have available, the countries who have the largest distributive impact could be Chile, Argentina, Colombia, and Costa Rica. Are the countries in which you have some type of social health insurance systems. When we look to the countries in which they have the worst performance in terms of income distribution, we look to the poorest countries of the region in which government spend very little, and in which the little expenditure that's been done, 30% of the expenditure of government go to the top 20% of the income distribution. So looking to the governance of the healthcare system, I think we need to look to the whole picture. It's not only the public sector as such. We need to look to the whole healthcare markets and try to see how can improve the way in which system perform. And I give you only two indicators of performance of healthcare system. In terms of health outcomes, and we have very strong evidence that having a strong public healthcare system, where it is social health insurance, where it's a national health service system like the UK, like it is the case of the Caribbean, we will have good health outcomes, better than the rest of countries that have the mixed healthcare system in which government play a very little role in terms of expenditures and in terms of distribution. And in terms of income distribution, in terms of equity, we also find that the worst countries in terms of income distribution are those countries in which government spend very little. That is also some of the countries in which Maureen find there is a lot of corruption. So let me stop here and open the floor. He will open the floor for discussion, but let me give you this broad picture of healthcare system that we're talking about, completely different structure of healthcare market in which we need to implement some policies to address these issues that are borderline between corruption, mismanagement, and governance. Thank you.
Thank you very much, Rubén. We'd like to open the floor to discussion. We have a couple of microphones circulating around. When I call on you, if you state your name and your affiliation, please. If you're an NGO concerned with healthcare in an international setting in a specific country, and you only have a mandate to look at healthcare.
Oh, I see. Well, I think unless you have some sort of a dynamic leader who decided that this is the thing that he's going to take on, and that individual has the support, political support within the country, I think you can do that. If you don't, I think it's much more difficult. I mean, if you look at the successful programs that I know of, Nigeria, for example, Obasanjo had an anti-corruption agenda. His the head of the drug what do you call it, the drug fund for the government went after corruption, and had death threats, and had to have separate special support. But it was a general focus of the government, and they were doing that. If you talk to somebody like Kabaruka, who's now head of the African Development Bank, but used to be in Rwanda, he said, the way we started to address corruption was we dealt with the tax system. It was something that affected everybody and made clear that we had an agenda, and everything else could come out from that. That didn't mean we got rid of corruption, but we got at the root of one of the biggest problems. And I think if you take just health, it's much harder to do, unless you're sort of a unique situation, because I just don't think there's enough power within that ministry generally to be able to do that. And when you have the support of the whole government, it's much easier to do.
Back here.
Thank you. My name is Elizabeth Schenecker. I'm from USAID's Global Health Bureau. My question is for Dr. Lewis. I really appreciated the fact that you gave us some practical interventions, things that can be done in the health sector to deal particularly with what you termed the mismanagement kinds of things. I was wondering, well, my question has two parts, really. Is there a country or countries that have actually tackled that in the public health sector? And if so, how did they do it? I think the what to do that you gave us is really important, but I'm curious to know how one gets going on this. I mean, does it need like a strong champion in the public sector to take it on? Is it NGOs and civil society that do the pushing, or how does this actually get going and get started?
Well, that is the crux of the problem. If you look at a country like Poland, it was a national attack on corruption more generally, and basically saying we're not going to accept corruption. I think corruption often in health is hidden on the public agenda side, but people know about it, and people in government know about it because they've come up against it. And what they've done in some places, for example, in Argentina and in Colombia, as Rubén had touched on these countries as being more equitable, what they had done was they set up price lists that should be used so that they knew what was going to be purchased, and that reduces corruption. Chile completely revamped its procurement process for drugs, saved them a lot of money, and they used computers. They used computer budgeting, so everybody knew what was there. It was completely transparent, and they lowered their costs. And they separated the procurement from the distribution. The distribution was also done on the basis of computers. And that's not so difficult anymore, even in the poorest countries. But it reduced their costs, improved their distribution, made the right drugs available at the right time. I don't really, to be perfectly honest, I don't really know in health what the impact has been of NGOs. I do know that there have been cases where governments have tried to work with them. In Cambodia, what they did was, and also in Haiti, they tried programs where the government contracted out to private entities to deliver services. And that's worked relatively better than the public system because you can hold them accountable more easily. You're not trying to fire a government employee. You're saying this contract was not fulfilled, you need to find somebody else to do this, or, I mean, it's much easier to hold them accountable. It seemed to work quite well there. It's worked in, Bangladesh has had some experience with this too, and that's worked rather well. At the hospital level, they've done a number of things where they've empowered the hospital director. I mean, one of the problems in healthcare is that you have hospital directors that are powerless. I mean, when I did a very in-depth study in the Dominican Republic, and the director didn't have the right to have the cleaning crew work on the second floor instead of the third floor. They could only work on that floor, and if they didn't show up to work, there was nothing he could do. And he had his cadre of physicians, and even the ones who didn't show up or the ones that were incompetent, he couldn't do anything about. They knew that. So he had no authority. So I think that's not rocket science, but it is sort of a way to provide some management in the system and to hold that director accountable. And that's not been done very much. But it has been done in some places, and it's been done in a lot of Latin American countries, and this autonomization of hospitals. There's a new study that's being finalized in Brazil where they find much better performance and impacts with hospitals that are autonomous, but also held accountable than on the other hospitals. So I think those are the kinds of things that work. And, I mean, I don't know how many of you know about this rather celebrated case in northeast Brazil, in Ceará, that had community health workers, and they showed up to work and they did really well. Well, something that gets missed in that story is that they were hired on a contract basis, on an annual basis, and the community leaders endorsed whether or not they wanted those people back in the second year. And those kinds of incentives really do matter. If you're not sure whether you're going to be employed, you show up for work, and you want the people who are making the decisions to know that you've done an acceptable job. So I think those kinds of things can be very powerful.
Yeah, the two people, let's take two questions from the two on this side here.
Thank you. Just on that last point that you made, one NGO intervention that you might want to take a look at is something called partner-defined quality, which is when NGOs work at the local level with local communities as well as health providers from the local facility. And from what I've seen in Nepal and other countries, it actually is extremely effective at not only increasing the effectiveness of the delivery of services, but also transparency and most likely reducing corruption. But I just wanted to go back to your one of your earliest points about the distinction between mismanagement and corruption. It seems to me that one of the key differences is that corruption is a crime and mismanagement isn't. And I didn't see anywhere in your brief or in your presentation any mention of using the justice system to reduce corruption. I was wondering if you could speak about that for just a bit.
If you could just pass the microphone along to the woman here. That doesn't work, sorry. Right there.
Thank you.
Yeah, it's working.
Okay, thank you to both of you. My name is Miriam Carcenobre from GW. And I thank you for the presentations, very complete, very nice, and very clear. I have some questions. When you talk about absenteeism of one part of corruption, did you take into account other incentives that sometimes change the fact of absenteeism? For instance, in many middle-income countries in Latin America, there are university hospitals, are state hospitals, and free access for poor people, for any person. There are some kind of fees according to the earnings of each person. But physicians are and nurses are very willing to go because the precedent for academic background compensate the hours, and they accomplish the hours for they spend over there. And I wonder if you compare university hospitals with other hospitals, because in most of Latin American countries, this could be a difference, as it is the kind of residence required for be able to perform the profession. For instance, in Peru is CESIGRA. I think there are, in many Latin American countries and some Caribbean countries, there is a requirement to provide community service. This is the first question. The second question is regarding accountability. If you compare hospitals in which part of the directing board is community representatives, because we don't know if this is because the presence of the community with force or the feedback to the community for preventive measure or avoiding risks. This is the other question. And you focus, both of you focus in corruption at the lowest levels, operative levels. There are other levels of corruption, for instance, the buying of technologies and drugs that are obsolete in industrialized countries, opening markets in underdeveloped countries and middle-income countries. And this is very concerning, not because there is a better drug, because the risk for a drug that is being massively used is not known on due time. Thank you.
Another question.
Let's take those two.
Do you want to? Okay. All right. I'm going to pass it to Rubén after I've asked this. I think the idea of having NGOs working with governments is fine. The question that I have is, if the incentives aren't in place, what happens when the NGO leaves? And that's one of the real challenges that I think we find in a lot of countries, where there's something in place for a while that keeps things working well, keeps things transparent, and when that leaves, that there's got to be something in place that keeps the incentive there to keep that performance up. But I do think that those kinds of things can give guidance. And one of the things we found in a lot of developed countries is total quality management, where you bring in the workers in the hospitals or in the clinics to help you solve problems of how to make things work. Tends to actually get you to greater transparency and higher levels of quality. And I completely agree with you of why corruption is different. It's a crime, absolutely. And I think if you let it go, even if it's small, then, everybody else sees and says, well, that's the game, we've got to do that. And you see that in very clearly in parts of the former Soviet Union that really survived that way. But why don't they use the justice system? Most places where you've got a lot of corruption, your justice system isn't working very well. Even in Latin America, which is pretty sophisticated in a lot of ways. The justice system is slow, it doesn't work, and it doesn't work for corporations that have a lot of money and want to push the system. And trying to prosecute physicians is really tough. In Brazil, I looked at this in Brazil in the mid-90s, and the number of complaints they had was something minuscule. It was sort of 25 complaints a year. 5 of them were adjudicated, and none of them chastised the physician. So I think it's a hard thing to use. The U.S. uses it a lot, but most countries don't. Even European countries don't use the justice system very much for some of these kinds of problems, and in other parts of the world, almost not at all. Partly because of status issues with physicians, and unlike the U.S., where we question physicians all the time, in a lot of countries they don't. The absenteeism in university hospitals, well, I think that's a question of just incentives. You have an incentive to come to work because it's part of your program. If you don't come, they know you don't come, and you don't, so your absenteeism is low. But I think that's a very different kind of issue. And no, I don't think everybody's compared those, but I think part of the reason is that. Although, I will say, in the Dominican Republic, in the hospital I mentioned before, the interns had absolutely no supervision. I did time and motion studies. The physicians were never there. So the interns were winging it on their own. So they were showing up part of the time, but the physicians who were supposed to train them never did. So, it's sort of a mixed bag. As to the boards of hospitals, I've worked in Latin America with boards of hospitals, and I think the community leaders get captured by the director, and they look at very broad things, and they never really get at the. Now, that there are exceptions, and we've tried to do that in a lot of places. Part of it is the boards don't know what they're supposed to do, and I think there's been a lack of sort of leadership as a result. But maybe Rubén knows areas that I don't know. Rubén, you may want to answer some of these.
In the areas of government intervention, there are many things that are continually explored to try to see how we avoid corruption. For instance, community participation in hospital boards, or hospital autonomy, to try to see how we can improve the systems. So there are many initiatives, but always you put something, always there is a space, because of the way in which the market works, always there is some space for quasi-rents that give you the incentive to try to get the extra rent that is corruption. Now, in the sense that you mentioned, we don't know how many people have been prosecuted for buying or for doing illicit operations. Many ministers are always leave office with a legal suit accused of corruption. But so far, I don't recall any Minister of Health or many Minister of Finance or any president of the country, who went to jail, the Costa Rica one only, that because of corruption have been indicted and is in jail. So, it's not in jail. It's indicted.
Not necessarily in jail.
But I think it's important that you look that the countries are doing this effort to try to combat corruption. And this corruption, as I mentioned to you, is a kind of new standards of how the government should operate that just came in place in the late 90s. The second thing with the question about high-level corruption. 2 months ago in Chile, there was a huge debate because the institution that Maureen mentioned, Senabas, that is the procurement agency for the government, decide to buy some type of, I don't know if it was insulin or not, I don't know which type of supply from an Indian provider, from a manufacturing company in India. And then the private company, the other big company, said that was, supposedly there was a bribe in the system. And there was a full debate, there was in the press, they were for the resigning of the minister, the head of the Senabas. And then it was proved that the safety of the drug from India was similar to the one in the market, but there was a whole issue about corruption because procuring from a cheaper provider that was not one of the regular players in the healthcare markets. The other example that we can have is in the case of introduction of new technologies. We have recent two cases. Two new vaccines are coming to the market, rotavirus for diarrheal diseases and HPV for cancer, cervical cancer. In one of the countries, I will mention the country, the minister decided that rotavirus is bought and is introduced. And in other country, the minister said, no, I won't introduce rotavirus. Then we find out in the country who said, we are going ahead with rotavirus, the company offered to build a plan for the production of vaccines in the state in which the Ministry of Health is coming from. Is that corruption? I don't know. I don't know what type of thing is going on there. But it's not unusual to try to find that some decisions are made. Could be with World Bank projects, could be with the IDB projects, in which you have a suspicion that something is going on, but we have not been able to prove that corruption in the sense that somebody ends in jail happens. And finally, I think in terms of how we can combat corruption and how to address in terms of data and transparency. I think the work that the IMF is doing in terms of integrated financial systems for the public sector, I think is great. If we can expand the work that the IMF is doing in trying to see how funds are moved through the system and how they are used, we can improve the way in which in the health sector government funds are being used and give account for it.
I'll take these two right here in the middle.
I'm Alan Moore, a fellow at the Global Health Council and at CSIS. My question may be for others in the audience, because I'm guessing it wasn't covered by what you're doing, but the work you have already done. We've got an enormous number now of new experiments going on. We've got 15 PEPFAR-focused countries. We've got 3 Presidential Malaria Initiative countries, 4 more to come. We've got global fund activity. This is a huge infusion of new funds. Sometimes it's, my understanding, it's creating a bit of a parallel system, but in every case, there has to be integration with the local system, which is broken, poorly governed, corrupt, whatever. And I'm curious as to whether anybody in the room has some comments about how the administration of some of those programs is going on in light of the governance corruption challenge.
Hi, my name is Agima. I am from URC, working in Benin, West Africa. Thank you for your presentations, but coming from the field in West Africa, I have some questions. First, how can you address corruption in a politicized health system? Usually, if a director has been assigned for political reasons and he should bring money for the party, and the other divisions, heads, are here just to get money for the party, how are you going to address corruption issues in this institution? The second thing is that what is the role of donor agencies who know that, money has been chopped by people or even by the Minister of Health? What is the role of donor agencies in the fight against corruption in public sector? I have an example from Niger, and now I want to talk about political will. The national hospital in Niger, the prime minister appointed somebody and said, I want you to make your job. And he made a list of people who are those who are giving tough time to all the directors who try to fight against corruption. And he get those people moved from the hospital. Now, his budget his budget, I mean, in terms of recovering fees, went from 46 million to 176 million after 5 years operation. And the intra-hospital mortality rate went from 26% to 12%. You know, and how do you fight against corruption without political will? Because in certain countries, you know, government just say, okay, we put in place, you know, a national strategy against corruption. We have a governing body against corruption, but we all know it is just empty boxes because the strategy is there. Even donor agencies are giving money, but nothing is, you know, happening at the field. And finally, I would like to, you know, the last question is, in most African countries, people operate in a very poor environment and illiterate environment. How do you address corruption in such environments? Thank you.
Okay, thank you. I think there was one more question over here.
Mine is short. Vic Barbiero, George Washington University. One, I know this is about public sector, but the way I see it in the future, the public-private sector interface is going to be key. And one question for the panel is the private sector any less corrupt than the public sector in a lot of these countries, and are there any lessons that could be learned there? And just one point of clarification for Rubén. I thought I heard you say, based on your examples from Chile, Argentina, Uruguay, Costa Rica, Cuba, that there was basically a direct proportion between the money allocated, okay, and good governance. I was just wondering if money allocated to the health sector, percent of GDP, et cetera, and good governance and performance. I just wanted to expand a little bit of that on if there are any data, and because those countries are a little bit different than the norms that we see in a lot of other, even Latin American countries, but also certainly in Africa. Thank you.
Okay, let me take this issue of the Global Fund and PEPFAR, and I mean, I think this is a really big problem. I did a paper on this, and I think that we're headed for a train wreck for the reason that you gave, and that is that we are putting lots of money into a parallel system and no money into these other systems. So they're just going to deteriorate. And I think that the unfortunate thing about that is you need those health systems. When you're talking about AIDS, you're talking about opportunistic infections. When you're talking about malaria, a lot of the diagnosis is done in the health systems. And the donors, I mean, this goes back to one of the donor questions. The donors want to ring fence what they're doing. And I think that's a problem. And when you ring fence what you're doing, you put in something vertical. And the Gavi is now very concerned about this. The Global Fund is concerned about this. The bilateral donors are concerned about this, that the health systems have basically been let go because they're complicated, they're hard to measure what's happening, and so they've been bypassed. And now all of a sudden, you know, the immunization programs want to be taken on stream by the health system, and they can't do it because there have been no investments, and the best people have left, which is the other point you made. And I think that that's what's going to happen if you set up a vertical system like this and you don't care about what happens to this messy thing called a healthcare system. So I think things are about to change, and I think the GAO report on PEPFAR suggests that there are some issues. And I think there have been some Global Fund issues. I think there's a lot of money for individual diseases without paying attention to the context in which they have to function. So I think you've put your finger on a problem that I think is really difficult, and I think everyone's sort of waking up to it, but a lot of money and a lot of things are in place already to sort of move in another direction. So hopefully this acknowledgement and realization will make some move to get some change. So how do we deal with corruption within a political pork system, which is really the question you're asking. That's why it's so difficult for a health system in and of itself to fight corruption without a broader overview of a broader structure of combating corruption. That's the first thing. The second thing is, you're absolutely right. There can be lots of empty boxes. We have this commission, and they're doing things. You go to Indonesia. Indonesia has taken some of the Supreme Court justices to trial. They've been serious. They have the backing of the president. And when you do that, you become serious, you fire a few people. In Nigeria, they fired some senior government officials. All of a sudden, it's pretty clear that there's some things you can't get away with. So a lot of the rules start changing. And it's hard on everybody because when you've been working in a system that's quite corrupt, you know how to work there. When it breaks down, you don't. And that's what happened, I think, in part of the former Soviet Union. People knew how to work in that system. When it broke down, all bets were off. There was no structure. And there was no transparency and an approach that was different that was put in place. It just broke down. So I do think you've raised something important, which is it can't just be pretend, and you've got to have some specific achievements that are there. You have to have some accountability. And if you have accountability, I think it can work. It doesn't always work, and you're not going to be 100% successful. If we look at the Medicare program in the U.S., we know there's a lot of corruption in the Medicare program. And there's some very good estimates of the degree of it. But the cost of prosecuting is also very expensive. So they've let it go. The question is, how long can you let it go before you have to intervene to make it clear that it's not a free-for-all of corruption? So there is a balancing act that is played. And, you know, if the PM is going to undermine what the Minister of Health does, the Minister of Health has no hope of getting corruption under control, which is why I think the overarching view that it has to be a national initiative is important. And I think your point about the kinds of things that happen with hospitals being much more efficient once you get a good manager and you have rewards for that, we've seen in a lot of countries. What you don't want is just that there are a few of them, but that they accumulate within countries and then across countries. So I think those are all quite important. On the illiteracy side, I really don't buy that because I think that you don't have to be literate to know that people are stealing money. And often people who aren't literate know exactly what's going on. How you deal with the accountability question, I think can be dealt with. It may be more difficult in a formal sense, but I think that's why some of this role for communities can be important. It's just that you've got to have enough authority in those communities that you can take on the physicians and the people who come from the central government who are providing services. And that's where I think the tension is. And finally, on the private sector being less corrupt. Well, it's corrupt in a slightly different kind of way. You're not taking public money and using it for your own gain. And I mean, the thing about the private sector is there's a market, there's demand and supply. If no one is willing to pay what you were charging, then you go out of business. And in the public sector, in parts of the world where you only have a public sector, if you don't pay them, you don't get any health care. And you certainly see that in Central Asia. Because there is no private market. In Latin America, there's a big private market. And what happens is sometimes the physician says, well, you know, I really don't have time to see you, but if you could see me in my private practice. There's a lot of that goes on. But you do get some level of care at the public sector. And you tend to have a little, I mean, I think in terms of the evidence that we have, the evidence on corruption in Latin America suggests that it's less than what you find in South Asia, which does have a large private sector, but it's somewhat questionable. I mean, we know, for example, in India, there's been a really interesting study looking at the sequence of use of healthcare in Delhi, and people use such a range of healthcare, public and private, that it's enormous. But in the private sector, they know what they have to pay. The amount is there, and you pay, and you get what you pay for. In the public sector, it's all rather shady. You know, you can come in, no, we're not charging fees because people are poor, and then you go to the doctor, and they go, well, if you don't pay me, I won't see you. And then he's getting a take. And that's a different kind of problem. And I think the lack of transparency in the public sector leads to those kinds of problems. And yes, you have corruption in the private market, but there are incentives there to check it and to keep it under control because insurance companies don't want to be overcharged. They're going to check those physicians that overcharge them. And the public sector tends to be more lax on worrying about that kind of oversight. Anyway, Rubén, I think you've got a bunch of things to answer.
No, yes, I will focus on the last question about good governance and good institution is not cheap. It's expensive. And you're right. Those countries and have effective governments is not cheap. We cannot run governments if you don't hire good professionals, so we have professionals who are working part-time. To give you a broad picture, those countries that I mentioned, the average expenditure, government expenditure is around 30% of the GDP. The poorest countries, and I give you the example of El Salvador, they are running 12% of the GDP. And when you talk tax evasion. I was in Paraguay just a few months ago, and 60% of tax evasion is kind of the way in which they say we don't have more resources. I said, well, but you have 60% of tax evasion. So I think good governance requires institutions. Institutions are expensive. Running effective government, you need good professionals. Paying for good profession is costly. If you want to have that, you need to use the fiscal space that you have to finance these institutions. And I think that's one area in which both the IMF is working on in the issue of fiscal space, and also the PAHO, we are working on how to use fiscal space to improve the governance of health sector institutions and the efficiency in which governments work in the health sector.
Okay, I think we're just about out of time. If there's any other questions, maybe our panelists could answer them after the session. Thank you all for coming, and we hope to see you again at the Wilson Center. Thank you. And then the Global Health Initiative, and also